This is a case of a decentered IOL due to an irregular rhexis caused during a previous surgery when this patient was very anxious, and she even moved and enlarged her main entry wound during surgery. Thus you see a suture there, and also extended the capsule rhexis during surgery, which ended up giving her a decentered irregular rhexis. We notice that there is a capsular fibrosis and adhesions between the anterior and posterior capsule, and also a overhanging thick capsular edge over the IOL. So we start by actually identifying the space of anterior and posterior capsule. So the best way to do that is we made another side port and used our left hand to enter inside the anterior chamber after viscoinflation and try and separate the anterior capsule from the IOL using a blunt rounded instrument. We actually create a space between the anterior and posterior capsule. This step has to be done very carefully because a lot of times you can actually end up tearing the posterior capsule. We realize that this maneuver has slightly loosened up the lens for us, but still is not achieving what we want. We try and push and nudge the lens back in place, but there are a lot of adhesions between the anterior and posterior capsule, especially on the right and upper part of your video, which are not letting the lens move back to its place. We re-strategize and then we actually try and rotate the lens in a direction so as to attempt to break the adhesions. Once we realize after repeated attempts that the IOL does move a bit, but it tends to come back to its original position. Though we notice that it is slightly better positioned than what we started with. Now we actually venture out a little deeper. Now this is a very tricky situation because we are actually working in that area which is not very visible to us. We again are able to achieve slight more movement because we have separated the anterior and the posterior capsular adhesions in that area where the IOL is not there. The anterior and posterior capsule have got stuck together and fibrosed. This is one big reason why the IOL will not go back into its original position. We again reattempt to actually break that zone. As we see, there is some resistance there, but yes, we did overcome that resistance. We ended up some partial adhesions. Now we will again attempt to see whether the IOL tends to go back to its position or not. We see some movement of the lens into that zone which we had just freed. Then we plan to identify the haptic optic junction of this lens so that we could know and estimate where is the opposite side haptic stuck up inside the capsular fibrosis. We negotiate and move the IOL in a slight dialing movement to free up the other hidden haptic. Once that is not achieved, we realize that there is a fibrotic band on the capsular rhexis edge which is actually constricting this capsular rhexis and also pushing the haptic along to the other direction. So we start by breaking this fibrotic band in hope of releasing this constrictive force onto the lens, and which is actually entrapping the lens and restricting it to come back to its position. We create, by breaking away this fibrotic band, we create a little loose area there. Now we proceed to actually cut the anterior capsule, and there we realize that we have actually achieved what we wanted to. We have broken the fibrotic band, and with the sudden snap sign or breaking up of that, we will notice that the IOL has actually slightly snapped better into its position. Now we want to extend and break as much of this band by the tearing movement in that area which is hidden from us under the iris. So we try and do a peeling movement, and yes, we are successful in breaking that fibrotic band which is going underneath the iris and hidden. We go in with a micro forceps and trim that capsular tag. The fibrotic capsular tag is then removed using a micro forceps. This has created some space for us within the capsular bag and the constrictive forces of the capsular fibrotic tag are reduced. Now we all will notice that the IOL is more mobile than earlier and the constricting pushing forces are reduced, but still it has not achieved what we wanted. We try dialing the lens again and see whether we can now dial the lens in its position. Once that is not achieved, we go in, push viscoelastic into the anterior chamber, and then we plan to actually negotiate the haptics under the capsular axis and try and loosen up the haptic which might be stuck under the capsular axis. We manage to engage the haptic optic junction of the IOL underneath the capsular axis. Now we do repeat the same maneuver on the opposite side and attempt to dial the lens out of the adhesion and into the free area. Some slight amount of dialing was possible and the IOL is again now starting to center up. We again attempt the same maneuver and free up the haptic which could have been caught between the anterior and posterior capsule, and we dial the lens back in place. Now mind you, this dialing would not have been possible if we had not freed up the anterior and posterior capsule adhesion on the right side of your screen. Once these adhesions have been broken, the IOL now has some space to get into the anterior and posterior capsule. Otherwise that would not have been possible and the IOL would be decentering again. We have now dialed the lens back in place, but still a slight amount of decentration is coming because of probably the constrictive forces of adhesions between the anterior posterior capsule and the fibrotic overhanging capsule on top of the IOL. We proceed to give a nick and relax this overhanging capsule so as to create a loose effect or loosening effect on top of this IOL, and suddenly the moment we have cut the anterior capsule, we realize that the tendency of the IOL to decenter on its own has disappeared. You will notice that the IOL is now moving freely within the bag and the tendency to come back is gone. Now this whole procedure has showed us one thing, that we need to in our mind imagine all the forces which could be decentering the lens. Doing this maneuver has ensured that we have avoided explantation of this lens, which in case of a complete fibrosis would have resulted in an intracapsular delivery and we would need to go ahead and put a sulcus fixated IOL, or a second option of cutting the haptics of the IOL within the eye and then placing a new lens within the sulcus. But this particular procedure which we have adopted has saved us all the trouble and gave us a happy patient. Secondly, using two side ports only for the surgery has its own advantage. If you notice, the whole surgery has been actually bloodless. There has been no chamber shallowing. Now in this situation, with a very large capsular bag, if we had a wound which would be a large wound or 2.8 wound, a constant shallowing of this wound would have probably resulted the lens to actually keep vaulting into the anterior chamber and maybe decenter again. So having worked through side ports only has made sure that we have a stable wound, a centered lens and a round pupil. Now this patient post-operative had all the cylinder astigmatism which had disappeared. Thank you.